welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I am your host, Shawn Needham, and I am streaming live from the Moses Lake Professional Pharmacy Studio. Actually, not the studio today, just my office. And I am super excited to have Dr. Marion Mass back on our podcast. She was on a few years ago, and basically talking about our healthcare system. And as you guys know, I wrote a book on it, basically the health insurance system, because it's not really healthcare that's the bad part, although sometimes care doesn't get delivered the best because of the health insurance problem. So I wrote a book on it a few years ago, Sickened, how the government ruined healthcare and how to fix it. And Dr. Marion Mass has written a few papers on it at least, and been very vocal about our healthcare system and some fixes. So we're going to talk to her about it today, and she's going to start out with some 3 big bullet points on how to fix it. Then we're going to get into the details. So Dr. Mass, welcome to our show.
Hey, thanks so much for having me. Pleasure to be here.
Yeah. So tell us a little bit. You just had a paper come out. We'll go ahead and we'll talk about this a little bit as we go through our podcast. But the 3 big bullet points from this paper. Tell us a little bit about it.
Absolutely. So I'll give you a little history first, and then I'll give you the 3 bullet points. So in 2019, I got together with a group of physicians and other experts in the healthcare arena, and we wrote the first free-to-care position paper. I mean, I had no idea what was about to happen was going to happen, but we took the position of stop having healthcare food fights. I mean, people will scream, repeal the Affordable Care Act. People will scream, Medicare for all. And both of those things they're bumper stickers. They're slogans. They're not solutions. They're not getting to the bottom line, which in that paper, the original free-to-care paper, we pointed out, it's the economy, stupid. You're all paying more. You're all getting less. And we should all care about that. Every citizen in America should care about that, because what we have right now is not affordable. The cost keeps going up. And when it's not affordable with a cost that's 1/5 of our nation's economy, it's not sustainable. And it matters for the future. So when we wrote that original paper, we gave, I believe, 34 actionable solutions. And then we put the paper out there, and all of these organizations came together. So Free to Care, the coalition formed. It's now 34 member groups, and that constitutes 8 million citizens, and 70,000 of those 8 million citizens, are physicians. So they're all agreeing with these are the things that we can do to try to fix our healthcare so that we end up in a more affordable, sustainable landscape. And we just updated the new paper. It came out in September. If I had to give you those 3 big points, they're open the books so we can see what we're paying and where the money's going. Cut the glut, get rid of all the useless stuff that's costing time and money to the American patient, and make everyone play by the same rules, because most people don't realize that, as the legislative tinkering has continued, large organizations, large industries in America have special rules. They're allowed kickbacks. They're allowed exemptions from transparency, or they simply just pay a fee and no one realizes that they're breaking the law. I don't understand how you can trust people who are breaking the law.
So, yeah, it is. I will tell you, and we've talked about it on this podcast before, that, I mean, the kickbacks and the stuff that happens in healthcare would be illegal in any other industry. I mean, it's just crazy, the collusion that goes on, and it's legal. So, number 1, basically open the books. You kind of mean transparency, correct?
Oh, 100%. I mean, like, my goodness, you can see what you pay for everything except healthcare.
Right.
I mean, like, if you want that new flat screen TV, you go to one store, you go to another. And look, I realize healthcare is a little bit of a different commodity. I understand, it is something that patients need. But at the same time, when you make it untransparent, when you continue to allow those who are profiting off the system to remain in the shadows, you're never going to get to the bottom of the cost. And if you don't get to the bottom of the cost, like, it's useless to throw around those little bumper stickers like repeal the ACA or Medicare for all. They're just slogans. Like, it's the economy, stupid. So look where the money's going. When you open up the paper, we give an introduction talking about like the status quo and why it's so bad. And then we go to a graph, and you can pull that graph up on your screen if you want. Maybe your viewers would like to take a look at that.
Is this one right here? That one?
It's a nice big colorful one. Hold on, I don't see it yet.
Right there, that one?
Yes, that one.
Okay.
Like, if you look at this, like when we took apart the money that we could see, and this is information from the health system tracker, like uh, except for other hospitals make up 31% of the national healthcare expenditures in 2020, but it's actually more than the 31% because hospitals now own a good portion of physicians and clinics. So shouldn't hospitals be the first place that we look when we're talking about transparency? But hospitals don't have transparent prices. We talk about how prices are so discrepant between different hospitals, how you can be paying like more than 10 times the amount for a colonoscopy in one section of the country than you would another.
Right.
And the patient, they're often anesthetized against that cost because it's covered up in their coverage, right? So like the patient, well, I don't have to bother to worry about that because I'm covered. But it does matter because if your coverage is paying for it, then your your premiums are going to go up later on down the line if you're paying out more for a procedure than you have to pay. And like actually the good news for us is that like, I think Americans by and large, we're kind of tired of the bickering and the fighting. Two presidential administrations agree that we should have transparent costs for hospitals. The Trump administration made their transparency executive order, put it out there in, I forget which year, I think it was 2019. And the Biden administration doubled down on the penalties of that Trump transparency rule. So we should be able to see in very simple format, machine readable files, how much hospitals are charging for each procedure, each surgery, each incidence of care, for the cost of their rooms. If you needed to have a baby, what it would cost at each place. And the Biden administration doubled down the fees on that. And that's great news, but there's two pieces of bad news. Number one, only 15% of the hospitals are complying. In other words, 85% of the hospitals are flaunting the law and choosing to pay a penalty instead, which goes to show you that like the number one health expenditure driver in America is breaking the law. I mean, doesn't it concern
Right.
everyone that they're breaking the law? And the second piece of bad news is when the Biden administration doubled down very quietly in the small print, they gave an exception for Medicare Advantage plans. Now, I don't know, you probably know these numbers too, and I may get them wrong, but I believe 90% of patients who qualify for Medicare have either Medigap or Medicare Advantage. I mean, like sort of telling us that they feel the need to get something extra on top of Medicare. You know how everyone says, well, Medicare, it works great. Well, if it's working so great, why do 90% of patients feel the need to buy something on top of Medicare?
Great point.
Yes, like, duh. But whatever the case, like for these private plans in Medicare Advantage, how can they get an exception? Why are we giving an exception for something as as elemental as transparency? Like if you feel the need to hide your cost, you're hiding something. And if you're hiding something, it must be because you have something to hide. And so when you don't have transparency, you can see in a setting of coverage where we rely upon coverage as our model, you can see in like the second page after this nice graph, you can see how we have like a rise in expenditure, especially in hospitals. So if you pull up that next page of the paper, so take a look at this. Look at this top line here. Hospital prices have been growing more rapidly than other goods and services since 2000. There's actually an updated 2021 version of this. I found it on American Enterprise Institute. Like someone in there like has graphed this out. They get it from the Bureau of Labor Statistics. It's outpacing college tuition. I mean, we just graduated one from college and we have two more in. And I can tell you it's like shocking what's happened to college tuition. My husband and I went to Duke University Medical School. When we started in 1990, our tuition was $14,000 a year. I can tell you that even for the undergrads, it ain't 14,000 a year anymore. It's done this kind of an increase. So if you think about the location, we can see where most of the dollars is going from the previous graph, hospitals, which is way past, a third. And you see the incredible rise in hospital service cost. Why aren't we all demanding transparency? This is a kitchen table issue. It's not a red issue. It's not a blue issue. It's an American issue. We should all be able to see what it costs. And just demanding to know what hospital prices are doesn't mean that I'm against people getting care. I mean, this is the most elemental thing we could do. So before we even get to talking about let's build a new system, how can we build a new system when we don't know the economics of the system that we have right now?
Yeah, asking the price of any goods and services is it's basic econ. It's basic free market principles where a consumer and a vendor of some kind of services, there's that transparency in price, and it's a transactional relationship. Why should healthcare be any different? And when I look at these graphs comparing college tuition to healthcare, both of them are obviously moving up very fast and outpacing inflation. And I think one of the things that they have in common is that somebody else, especially the government, is paying the bill. And that's why you can lack transparency, because somebody else is paying the bill. If the consumer was responsible for their own payment, then, there would be transparency, because the consumer would either decide to get care or not get care. And by the way, that doesn't mean they wouldn't get care. It just means care would be a lot less expensive. You go.
100%. Well, yes, you said the government is paying the bill. The government isn't paying the bill. The government doesn't do a darn thing unless they extract taxes from the public. I mean,
that's right.
We are paying the bill. Thank you for correcting me.
And I'm just going to say, and I'm just going to say, taxes, they are extracting them if we don't pay our Medicare tax, we go to jail. So, that is coercion. That is like stealing from somebody, literally. I know that sounds very powerful, but I believe in that. And that's one of the reasons they were able to get away with these bloated programs. Go ahead.
Oh, no, absolutely. Well, it just seems to me very simple. We are paying the bill. So we as taxpayers, and if you're not paying taxes because you're not in a fortunate tax bracket, it still affects you because we're paying more than we should, and we don't have enough to pay for everything that we need. I always use the word need. I don't like to use the word want. I don't like the words right and privilege in healthcare, because I don't view healthcare as a privilege at all. And I don't like calling it a right. What I like calling it and terming it is a need. But once again, right, privilege, it's a healthcare food fight. People will have various needs throughout their lifetime, and they need them fulfilled. But if we don't have a sustainable system, we're not going to be able to fulfill that. And we should all care, because it's collectively all of our money. A lot of people don't find finances interesting. Frankly, I don't either. I don't like them. I just know that if I make money, I try to save it, and I don't.
Right.
I'm like the kind of classic, why pay more in all settings. I shop at thrift stores. I still do. I guess I could afford to not shop at thrift stores, but I say, why pay more? And I look at this the same way. Why pay more? And I can't even see where some of the money is going. So I think the other thing that hospitals and colleges hold in common, I call it administrative bloat.
Tell us about that. Get rid of what? What are we going to get rid of?
Well, I said cut the glut. If there's a graph running around out there that has a graph, it graphs the increase in administrators in healthcare, and it's just an enormous rise. I think it's a almost 2,500% increase in healthcare administrators. At the same time, a very small increase in physicians. And by the way, I'll talk to you how we're having a doctor exit, and what we saw in 2021. But so the people that can take out your appendix, diagnose your pneumonia, deliver your baby, resuscitate your baby, like their numbers are not increasing, but the people that are pushing all the paper around to fulfill all of the bureaucratic wants and needs and mandates, those people have exploded. And I call that's why I said that in that little phrase, like open the books, show us where the money is going, cut the glut of these regulations. I mean, do we need another paper pusher in healthcare, or do we, like, can you actually call up a physician when you need medical care and get in touch with one, or are you having trouble accessing a physician? I mean, I can tell you, my little phone here, and my odd video keeps on cutting out, but my nice little pink phone here goes off probably about, I don't know, 7 or 8 times a week among my personal friends, and I'm happy to help them, but they're like, well, we can't get into care, and we need this and we need that, and what should we do? I mean, I'm running out of options to help, because in the midst of the increasing costs and us all paying more, we're having a great doctor exit.
Yeah.
So in 2021, 117,000 physicians left the practice of medicine. I mean, there's less than 1 million physicians in America anyway. I mean, what are you going to do when more keep leaving?
Yeah.
Well,
I look at, like, the thing is that when we talk, some people think that we might be a little bit crazy when we're thinking we can fix the system, but just realize this, you're talking about all the administration. So I worked in a hospital almost 30 years ago as a pharmacist, and that wasn't that long ago. And back then there was basically a CEO and a CFO. I don't even know if they called it a CNO yet. I don't know if they had a chief nursing officer. They had maybe a nursing supervisor. And now at that same hospital, there's no more physicians as far as practicing physicians. There's employed physicians now, but there is a lot more administrators. And, back in the day, there used to be a doctor, a nurse, and maybe a nursing assistant / receptionist. And they took care of all the clinical needs, and that's all they needed. And so a lot of this administrative bloat you're talking about is unnecessary. And the problem is their paychecks are dependent on it. So there's a lot of people that lobby against changing the system because they want to get a paycheck. And now those administrators, I remember back in the day, not too long ago, 30 years ago, where, doctors were the highest paid people in the healthcare system. That is far from the truth now. The administrators in hospitals are making way more than most doctors. You go.
I love how you do that. You go. Sure. And I never advocate to say increase physicians' salaries, although I do think what we do need to pay attention to is we need to pay attention to the younger physicians, because the younger physicians, so you go back to that second graph where the college tuition increased, the medical school tuition increased too. So I'm lucky to be able to advocate, and I don't take speaking fees. I don't take writing fees when I advocate. I'm happy to do it, but I'm able to do that because I didn't have these, high tuition costs. I graduated before that graph even started from medical school. I'm very fortunate and lucky, but our new younger physicians, I think we have to kind of come out with something for them to be able to balance out what they put in, when you're the patient and you go into the hospital, and let's just say it's 2 a.m, and you're a 45-year-old person and you have a hot red appendix, you're going in there and you have a healthcare need, right? So what do you need? You need someone, the ER doc, to diagnose your appendicitis. Most of the time it does happen with a CAT scan. If it's obvious clinically, maybe they won't even do the CAT scan, but unfortunately we live in a medical legal world, so no one wants to slice you open unless they know that they need to. So you probably need the CAT scan. Then you're going to need the surgeon, and you're going to need the anesthesiologist. And we haven't even talked about where the paper is getting pushed around. But all of those people, you don't want someone slicing you open that doesn't have a lot of training. You don't want someone passing your gas, as we say in anesthesia. You don't want someone that doesn't have a lot of training. The training is you worked really hard through 4 years of college to get into a good medical school. you worked your tail off through 4 years of medical school, and then you, like, if you're the general surgeon, it was 5 years of residency, and I can't remember if it's 3 or 4 for anesthesia, but all of that time, the medical school, the college undergrad, that all cost money. So our younger physicians that are coming out have these extraordinary loans, and they're coming out and then they're discovering that, they're facing another 4.5% Medicare cut. We're getting cut. Our profession is getting cut in a setting of us making 7.3 cents on the healthcare dollar. That's all we make. 7.3 cents on the healthcare dollar. I'm not saying expand the 7.3 cents, but if we took a look at the rest of the pie, the other besides the 7.3 cents, where's all that money going? Because if it wasn't for that anesthesiologist, that ER doctor, that surgeon, the people that stayed there in the middle of the night, those nurses that were there, the CT tech, the radiologist who read the CAT scan, you'd be in a big pile of trouble. And your appendix would burst, you'd get sicker, and you'd still need the hospital, and you'd still need the surgeon, et cetera, et cetera. Now you need more meds, you'd have a longer stay, and you'd be in trouble. But when you come out of there, you don't know where the money went. And if I just got over telling you that the physicians are making 7.3 cents on that healthcare dollar, where's the rest of it going?
Yeah. Well, I say this quite often, and some people don't like what I say about it, but I truly think that hospitals have created a cartel with insurance companies, and they're in collusion with insurance companies to create a cartel to rip off the consumer. I really honestly believe that, and we already talked about that. I mean, if that's not the case, then how come they're not transparent on pricing? I mean, seriously, it's just a question we should ask. And I think hospitals are really guilty of this. I think we have to really, really, nail them down. I mean, to make some changes, and transparency is the first step.
Absolutely. It's also very interesting, and there's been a lot written about this in the last couple of years. We brought it up in the first paper, and we bring it up in this paper as well. These so-called nonprofit hospitals are, if you look at their administrators, someone's profiting in there. So, I'm going to blow the whistle and call like a little bit of there's some badness going on there. Yeah. And not only are these hospitals profiting, but, the whole idea behind them is they're nonprofit. They're not getting taxed. And then they're going back when the patients that are indigent can't pay, they're suing those patients and they're collecting. And there's actually now been some, interesting investigative journalism work going on that's showing that these very same hospitals, I read about this in North Carolina, these very same hospitals, these big hospital systems, they're kind of nudging their patients and sending them to these collection agencies, making it sound like, oh, this is great, this is no problem, this agency will take care of it. But these agencies are owned by either big banks or private equity funds, and then they in turn are pumping up what the patient owes. And so, like, the banks and the private equity are making money off of the fact that these patients have, can't afford the outrageous costs that they're paying. I mean, why not make what the patients would have to pay transparent to begin with, and like drive down the costs?
Right. And as if it wasn't crooked enough already, and hospitals didn't have enough of an income stream from many different sources. Somebody shared with me that there's some hospitals, they own their own collection agencies, another income stream for them. I mean, that just shows you that they're not really in the business of I mean, if that is true, which I believe that is, they're not really, their primary business is not healthcare anymore. I mean, seriously, how can you not argue that?
No, they're in the business of business. It was interesting. Our Free to Care conference this year in Austin, Dale Thalwell, who's the North Carolina state treasurer, it's an elected position. He was revealing to us, it was like, I thought the best moment in the whole conference. It was just like shocking, because he, as the state treasurer, is in charge of all of the employees of the state of North Carolina and their health care. he needed to know how much he was paying for them. And when he went to look at how much he was paying for hospitalizations, which, the number was like big, given the pandemic, because there were a lot of patients hospitalized during the pandemic. He went to UNC Healthcare Center and said, hey, there's a law, you have to comply with transparency, and I want a machine readable file, and I'd like it as a file, but I'd also like the paper version of it. So for you to send me what your charges are for all of these instances. And so he sent his request, and they sent back a file, and they actually even sent, I think it was like 300 and some pages worth of a 300-page sheaf, and it was all like redacted. So they wasted 300 pages of paper, but the ink that they printed it on, like, I'm kind of like a conservationalist, I hate waste, right? Like, why would you bother to print out like blank crap and use the ink for that, and the electricity that it costs to, and like he said, this is like a giant FU to transparency. It was UNC Hospital, University of North Carolina. Right. Everyone has these nice, like, oh, the sky is North Carolina blue, but it's like, well, dang, your transparency is up there in the clouds too. And like, so you're telling the elected state treasurer, you're flouting the law that 2 administrations laid down to say that you have to provide this machine readable file. And the state of North Carolina, I believe, is the biggest, they're the biggest buyer of healthcare in North Carolina. People in North Carolina ought to be furious, but then unfortunately, like, people have needs when they're sick, so they go to the hospital, and they need the hospital to stay in business. And I'm not saying hospitals should all go out of business, but I can't imagine being so obfuscative, did I use that word correctly, that you're going to like hide what you're doing. I mean, you can't make a good enough living in hospital setting with costs like that we just saw on that graph. You can't make a good enough living that you have to hide your prices and like thumb your nose at your entire state. Because you're not just thumbing your nose at Dale Folwell, you're thumbing your nose at the entire state. You're saying, we don't care. We're going to keep on collecting money, and we're not going to show you how much we're collecting. We're not going to show you how much what your needs are costing. Disgusting.
It is. So number 3 bullet point.
So we said, open the books, cut the glut, make everyone play by the same rules. Okay, so we're going to get to one of my favorite topics. I tried to stay quiet on this for forever, but we all know there's these like middlemen in healthcare, right? Like, so if you look at your pharmaceutical costs, which are a much smaller portion than the hospital costs, but if you look at your outpatient pharmaceutical costs, big pharma, they're making money, no doubt, but there's middlemen that are making more money. So let's just take like the example of insulin. And we all know that insulin has had a steep cost rise over the past several decades. Actually, the pharmaceutical companies are making less than they had been, but the middlemen, the pharmacy benefit managers, are making more. So if you look at the cost of insulin, they're chewing up 80% of the cost of insulin, and no one is doing anything about them. One of the things that I think is actually really nice is that since our 2019 paper, and since like a group of us have been writing about pharmacy benefit managers, and there's amazing people, way more amazing than me. I think of Anthony Chacha, David Balot does a lot of writing on this, Madeline Feldman. I'm going to miss people I know that have done some fantastic writing on pharmacy benefit managers. My apologies. People are now aware. So when we talk about just our outpatient prescription costs, people that don't do any research, don't do any manufacturing, who simply push the paper around are, taking more of the money than the people that are actually making the pharmaceutical products. I mean, we all point our finger and blame big pharma. And look, in our paper, we come down with some smacks on big pharma and the way that they keep their products evergreen. We say they keep the patents running, and they have all kinds of clever little tricks, and that's not good either. And big pharma needs to take their comeuppings. But if you're going to attack drug pricing, if you don't attack PBMs, you're not a fighter on drug pricing. You're a faux fighter. I'm going to call you a faux fighter on drug pricing. So all the stuff that we've seen come out in recent months, I mean, I'm not being a partisan to say this. The Inflation Reduction Act it gave the PBMs a free pass. Great that you're attacking pharma, but if you're giving the PBMs a free pass, you're a faux fighter on healthcare. The Affordable Insulin Now Act, the newspaper that I'm on the editorial board of, the Bucks County Courier-Times, our whole editorial board wrote a piece about the Affordable Insulin Now Act and how it's not living up to its name. It's not making insulin any more affordable. Lloyd Doggett, he's a Democratic congressman from Texas. He said that. I used his quote right at the beginning. This bill does not do anything to make insulin 1 penny more affordable. It just keeps the costs hidden. So these pharmaceutical benefit managers, people are starting to pay attention to them, and that's awesome. And one of the things that I've been talking about since 2018 with regards to the PBMs is they are legally allowed to receive kickbacks.
Unreal. I mean, it would be illegal. It would be illegal in any other industry.
Yes, but the 1987 Congress and President Reagan signed it into law. They gave them the legal right to receive kickbacks. And, people can jump forward and say, wow, that was Reagan's fault. That was the Congress's fault. And it was this lawmaker and that lawmaker. I honestly think Washington, D.C., they just listen to all the wrong players down there. People are down, the lobbyists are whispering what I call convenient untruths in the ear of Congress. Hey, Congress, do this. It'll make healthcare more affordable. How's that all working out for us? It's not. Stop listening to these clowns. Stop listening to the people that are making all the money. So one of the things that I believe we point out in this paper, and I've certainly pointed out in my writing, to give you an idea how much money these PBMs make. The PBMs have now merged with the insurance companies, so Blue Cross Blue Shield already owned their own in-house PBM called Prime, but CVS Health bought Aetna. So they bought an insurance company. They had $62 billion sitting around, so they decided to buy a PBM, right? Their PBM is 60% of their revenue. Express Scripts got bought by the big insurer Cigna. When Cigna purchased Express Scripts, its revenues tripled. So everyone wants to put the pin on the insurance companies, and they're right. They're controlling the situation, but their PBMs are their cash cows. Yeah. That's where they're making their money. So And
PBMs are literally, coming from a pharmacist, they are literally useless. I mean, they are doing nothing to help anybody's care besides taking money out of the system. That's all they're doing.
Well, look, I understand that you have to have some administration that goes on for the prescription once it's written, and someone needs to move it around and make sure that the patient is getting the drug. And I get that, but there are transparent pass-through PBMs that are not, part of the kickback scheme. And I think just like any, with all of our sectors of healthcare, with physicians, you want a transparent, good quality physician. You should want a transparent, good quality PBM. And these companies are popping up and thriving and able to make a reasonable salary, but doing so in a transparent manner. But the big PBMs are the place that I'm gonna lay the blame on there. And then I think
you mentioned CVS, right?
Yes.
They own their own. So just listeners, viewers, think about this. When you go into CVS pharmacies and you complain about the price, CVS, the PBM, the insurance company, Big Pharma, all four of those people are colluding to rip off the consumer. And let me just tell you this. If you go into any pharmacy and you just circumvent that process, especially with generic medications, and just say, I want to pay cash, you will save a lot of money. So I know you said there's good PBMs out there, Marion, but in reality, when the consumer deals directly with the pharmacy, you circumvent all that problem and you'll get a lot better service at a better quality at a lower price, especially with most generic drugs that are very, very affordable.
Yeah, no, perfectly true. But I do think most Americans are paying attention to PBMs, and
yes.
I shouldn't say most. Many more are aware. So and there's some bipartisan movement on this. Both Ron Wyden, a Democratic senator from I think Oregon, and Chuck Grassley, a Republican senator from Iowa, seem to be very on top of the PBM issue. So I think that's a good thing. I saw some hearings in the House in which over this past several years in which PBMs were taking a little bit of a beating. It was a big disappointment to see the Inflation Reduction Act because it gave a pass to the PBMs. And it was a big disappointment to see the Affordable Insulin Now Act because it gave a pass to the PBMs. And I think, for the people that signed on to that want to claim that they're fighting drug pricing, they're not. But the other middlemen that most people are not aware of, and I'll call your attention to, there's a group called the, oh gosh, I don't want to get this wrong, the American Economic Liberties Project. And they just recently put out a letter to the FTC. And our group, Free to Care, plus the physician group that I founded, Practicing Physician of America, signed on to this. Advocates urge the FTC to investigate GPO's impact on drug, medical equipment shortages, and rising healthcare costs. So GPOs are hospital middlemen, and GPOs, there's 3 of them that control 90% of hospital and nursing home supply lines. And so now if you think about, like we talked about how hospitals are sucking up a big part of the costs and how hospital costs have increased, in some cases, 40% of a hospital's overhead is its supplies. So GPOs have that same sweet deal as PBMs do. They have the right to legalize kickbacks. And so now we have 2 gigantic middlemen that when they got the right to receive kickbacks weren't so big, but they became bigger and more consolidated and wealthier over time. And it's interesting. I think they stopped doing it to me, but when I was sort of putting out there in the press that we shouldn't allow them to have kickbacks, I mean, I was just asking them play by the same rules everyone else plays by, right? Like if I took a kickback, I'd get nailed for it, appropriately so, and I might go to jail and I would pay a fine. But these companies are some of our wealthiest companies in America in healthcare are allowed to receive kickbacks. And, I'll put in there, I have like a great screenshot. It was made by a urologist in Florida named Jared Whalen. And he and I talk on and off, but it was like pointing out the biggest revenue generators in healthcare. If you look at the list, the top 11 on there, they all either own, are associated with, or are owned by either a PBM or a GPO. So like the companies that are making the most money in healthcare are companies that can legally receive kickbacks. It's like, duh. Like, why don't we just say no more kickbacks for you?
Right. We shouldn't be surprised.
Yeah. I know, but like, it's like, what's it going to take, Congress? Like they can't take kickbacks. Doctors can't take kickbacks. Nurses can't take kickbacks, nor should they be able to. The pharmaceutical companies can't, the manufacturers can't. So why are we letting these middlemen collect kickbacks? It's absolutely extraordinary. And then in the last chapter of our paper, we sort of talk about the need for a different kind of transparency, like the transparency of conflicts of interest. It's interesting, this very same American Economic Liberties Project, there's a guy that writes for them with a powerful voice, Matt Stoller, wrote an article about these GPOs and pointed out that one of the physicians that's very commonly on CNN is on the board and speaks often for one of the big purchasing organizations. It's like, what's that about? Is he getting speakers fees to do that? Because if you're showing up on CNN and you're giving your opinion all the time, I mean, might your opinion be swayed if you happen to be getting a secret, sweet little extra cash under the table for, speaking for these GPOs? It's a real concern. It's a real issue. So, right now in America, we do have like a sunshine for conflicts of interest that exists between physicians and pharmaceutical companies and device companies. I mean, you can look me up and you can see how much I'm taking from pharma and device companies. But like, how much are GPOs and PBMs giving to the press? How much are they giving to hospitals? How much are they giving to physicians? How much are they giving to physician or patient advocacy groups? All of that should be transparent, but it's not. Sunshine for all. I'm a sunshiny kind of girl. Let's take those conflicts of interest and put them out there. Everyone should show their cards on the table. I'll show mine if you show yours.
Yeah, I mean, it really is that simple. Why not? I mean, and if you're not willing to be transparent, it's like you said early on in the podcast, what are you hiding? I mean, seriously.
Yeah, transparency for conflicts of interest. Make
Yeah.
everyone play by the same rules. They made that Physician Sunshine database so that physicians, and I think it's great that we have the Sunshine database, because if you're concerned that your doctor is like pushing drug X, you can go take a look. Uh-oh, this doctor, they take a lot of money from this drug company, and maybe I don't trust this drug, and now I'm going to look into it a little more carefully. But there's no sunshine for, those other entities that I mentioned. We need sunshine for all. So, big picture kinds of things. America, healthcare is expensive. It's the economy. I'm not going to say stupid because I don't think you're stupid. I think you're misinformed. But it's the economy. And you need to make sure that you have healthcare for the future because it's a need. And we need to make sure that it's sustainable. And the first thing to start with is cost. So open the books and cut the glut of all these regulations and cut the glut of administrators that are sucking away your money. You're paying more and you're getting less. And lastly, make sure that everyone's playing by the same rules. If there's large, wealthy corporations that have rules that are special for them, you should be questioning why. We should be like taking the pitchforks down to Washington, D.C. and demanding that we open the books, cut the glut, make everyone play by the same rules.
Yeah, I agree 100%. And that's why it's so important for us to educate consumers about this, because all of us eventually, even if we're not a consumer of healthcare, we're eventually probably going to be. And it's important that we educate healthcare professionals about it, in every industry, whether it be doctors, whether it be nurses, whether it be physicians, whether it be pharmacists, because it's going to affect all of us and it's affecting our country. I mean, you shared the graph. We shared the graph from your report. It's not sustainable. The inflation rate of healthcare is not sustainable. We can't afford to keep doing what we're doing.
No, we really can't. Actually, last thing, and I should have brought this up when we were talking about transparency. I'm a big proponent of direct pay models. I mean, you brought it up for pharmacy, but it exists for physicians. It even exists for hospitals too. So there are direct primary care physicians and direct specialty care physicians that take membership models, and for the cost of like your monthly cable bill, you can actually have good access to a physician who is the abject model of transparency. It was very interesting watching in the pandemic, like, everyone was like saying, oh my gosh, now we're getting telehealth and it's a great thing. These direct care physicians were supplying telehealth for
I know.
years.
I know.
They were supplying transparent pricing for years in states where you can, and I know you're a pharmacist and I understand that there's like some, maybe all pharmacists don't like this, but in states where physicians can dispense pharmaceuticals, some of these doctors are dispensing pharmaceuticals and saving their patients a lot of money. And, people step up and they say, but it doesn't work for patients with chronic care. It's the patients with chronic care that need to be seen more frequently, that are thrilled that when they have a sick day, they're getting same day sick visits. That really doesn't happen for many patients at all in America.
And as far as physicians dispensing, I'm a free market kind of guy, so I'm okay with that competition. And I talk to doctors openly about it. And here's what I say: if pharmacists did their job in the first place and was transparent with pricing and charged, real pricing instead of insurance type pricing, physicians wouldn't have to dispense from their office. So that's my whole argument, is that if pharmacists weren't overcharging people already, it wouldn't be a problem. Now, there's a lot of pharmacies now, they're going with a direct pay model too. They're getting completely out of insurance. And those pharmacies, their prices are very appropriate, and they're a lot more competitive than a pharmacy that bills insurance, because they're more transparent. So, I believe that if pharmacists did their jobs in the first place, physicians wouldn't maybe have to dispense. Because if you talk to those doctors that are dispensing out of their office, it's very labor intensive. I mean, I know it as a pharmacist. You got to deal with inventory, you got to deal with outdates, you've got to deal with, labeling, all that kind of stuff. I mean, so if I had a direct primary care doctor right next door to me, I would just say, what do you want me to stock? And I'll take care of all your patients for you. So anyway, that's kind of a side note, but that's why I believe in a free market and direct pay in general, because those things will all work themselves out.
Yeah, absolutely. All right.
So Dr. Moss, as we wrap this show up, it's obvious what you have a passion for. You're very passionate about this subject. Thank you so much for, realizing our goal, which is to educate and empower consumers to take charge of their own health. And financial part of that is very important. So consumers need to know what they are paying for healthcare. So I have your LinkedIn streaming here. What is another way that somebody could get a hold of you?
That's probably the easiest. I do take messages there. I'm on Twitter as well. I think it's at Mass_Marion. I don't have like the following of the stars that some people have, but I mean, I don't know. I think I get a good many people that pay attention over there, and you can find on both of these places some of the same characters that are fighting for the same thing that I'm fighting for. I mean, we want a better future, and it needs to be affordable. It needs to be sustainable. So
Absolutely. I just realized when I looked at your Twitter page, and now I have to apologize. I was in Philadelphia. My wife and I were in Philadelphia a few weeks ago, and we should have looked you up. I apologize.
oh, I'm in the burbs, man. So, and like we actually, after we just got our third, he's just started college, so we're empty nesters now. So we've been doing a little bit of personal traveling, catching up,
Awesome.
celebrating our 25th wedding anniversary. A couple years late, but that's okay. It's all cool.
Yeah, awesome. We're in the same boat. And being an empty nester is it's life changing. It's cool. Yeah, so enjoy it. So
Yeah. Well, they're happy. So you know what? When they're out of the nest, I mean, I'm not going to be the mom who boo-hoos when the little my little ducklings, they're all happy little ducklings, busy little ducklings. So it's a good thing. So
awesome. Well, thank you so much for educating us today. And thank you, listeners and viewers for tuning in to Health Solutions with Shawn and Janet Needham. And I wish everybody a happy Thanksgiving. Enjoy time with your family. Thank you for listening.
happy Thanksgiving.